Hi, and welcome to Fade Out Depression. I'm your moderator for today, Tabitha Washington. Here's a little about our program. We're partnering with Barbers in the Philadelphia Lancaster metropolitan area to raise awareness of major depressive disorder. It is known that the barbershop has been a staple in Black and Hispanic communities. It's been the safe place to discuss anything from politics to cultural identity, even to healthcare. And we're working with barbers to educate them so that they can provide information to their clients on major depressive disorder. This Fade Out series is based on a study where barbers were provided information on heart disease and passed on to their clients for heart disease awareness. If you are interested in working with us on the Fade Out Depression program, please stay tuned. More information will be provided at the end of this program. Our faculty today are Caroline Barnhart.
Thank you for having us today to talk about this important subject.
And Kayla Weiler.
Thanks for having us involved in this project, and we're really excited to talk about health disparities and major depressive disorder.
Here are our faculty disclosures. This educational activity is supported by an educational grant from Takeda Pharmaceuticals USA Incorporated. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Here are our learning objectives. Discuss variation in depression diagnosis and treatment among individuals from racial and ethnic minority groups. Develop strategies that support treatment adherence and adequate response to treatment in people with major depressive disorder. Apply approved and emerging agents for MDD once available to treatment plans. And now we're moving on to our pretest. You will see these questions pop up on your screen. Please take the time to provide your answer. Question 1. Which of the following is true about the treatment of major depressive disorder among Black individuals when compared with white individuals? Black individuals are more likely to A, receive antidepressant medication in primary care, B, be referred for psychotherapy, C, experience delays in receiving medical treatment, D, be offered combination antidepressant and psychotherapy. Please provide your answer now. Question 2. A 45-year-old Black woman with newly diagnosed MDD was started on an SSRI 6 weeks ago. At today's visit, she reports she stopped taking the SSRI 2 weeks ago because of fatigue and weight gain. What is the most appropriate next step to improve treatment adherence and response? A, increase the SSRI dose to improve efficacy. B, educate about expected side effects and strategies to mitigate them. C, refer to a psychiatrist without addressing adherence concerns. D, add a second antidepressant to address incomplete response. Go ahead and provide your answer. Question 3. Which of the following has demonstrated increased rates of remission of depression as a switch agent after inadequate response to first-line antidepressant? Aripiprazole, bupropion, cariprazine, vortioxetine. Please provide your answer now. We'll revisit these questions at the end of our program. And now I'll turn it over to our faculty.
We'll start this presentation by going over some of the disparities that are typical in the Black and Brown community surrounding major depressive disorders. And then we'll pivot a little bit later on in the presentation to talk about some treatment interventions and opportunities to help treat this particular diagnosis. So to start, let's kind of create a foundation of understanding about the different categories that are impacting this population. In terms of categories, we're going to look at race and define that as the true physical attributes that people bring into their care experience. Research has historically suggested that there are a lot of biological differences across races, and we'll talk a little bit later on about whether that's fact or myth. Ethnicities can also be explored in this paradigm. This is more typically looking at something like language, religion, or nationality, similarities and differences across groups. And ancestry will look at the geography or the true genetic descents of patients and their experience. This is often a little bit disproportionate in the research. Many of the things that we know about people and differences utilize the white European populations as like the gold standard or catalyst for metrics. So that can sometimes really influence the way that we perceive differences or assume that there might be differences in medical and behavioral health diagnoses. Another thing that's important to consider is that many times we interchange these three categories, which can sometimes create a lot of confusion across groups because genetic differences, physical attributes, and cultural differences are not synonymous. Another important thing to consider is that what we perceive in ourselves may be very different than what other people perceive as an external observer. And these three contexts are very fluid and change across time. So what was true perhaps a decade ago will be very different a decade from now. We'll start first with the biological differences across racial groups. What research had tried to say in the past is that there is racial differences across biology. And what we've found over time is that the genetic variations across human beings only accounts for 0.1%, very small amount, which kind of links into this really great quote that if you're trying to establish racial boundaries through genetics, that fallacy needs to be corrected. 0.1% would not be enough of a difference to say that race, in fact, impacts biology. We'll also define major depressive disorder as its diagnosis. And there are some really key features about this diagnosis that we should consider. The first one is that there are 5 or more symptoms present in a patient during a 2-week period that causes a significant change in their regular activities. Some of the symptoms you can observe might be decreased mood, pleasure, weight loss and weight gain, changes in their sleep or energy levels, feeling worthless, perhaps having challenges in making decisions or choices, and having thoughts of harming themselves or thinking more frequently about death. It's important to make sure that we rule out any other contributing factors, which may include substance use disorders or other medical conditions. If the symptoms are in relationship to any of those two, we should make sure that the symptoms are present without those factors. In terms of prevalence, there are about 300 million people in the whole world that are diagnosed with major depressive disorder. And we can look at this very uniquely in terms of racial groups as well. In 2018, we saw that Black and Hispanic individuals have an equal rate of depression as white individuals. But when we drilled down to actual diagnoses and symptomology, we started to find some differences. COVID-19 also really expanded upon how many people were experiencing mental health symptoms. It was present that many people had worsening symptoms during COVID-19, and in particular, the Black and Hispanic communities did as well. The PHQ-4 is a screening instrument used to identify the presence of depressive symptoms. Black individuals were 16% more likely to score positive on this screening than white patients. There's an additional question on there that asks about how frequently someone is feeling sad. And Black patients were more likely than white patients to report feeling sad most or all of the time. The rate of diagnosed depression for the Black community and Hispanic communities are different than what the white community is finding. 31% lower for the Black communities, and 39% lower for the Hispanic communities. Another interesting opportunity is that the frequency in which these populations are screened across racial groups also has some significant disparities, with the Black community being screened in primary care visits for depressive symptoms, the least compared to Hispanic and white groups. We can see that stigma is also a significant factor in health disparities. A survey of 2,700 adults reported that Blacks have a perception that perhaps individuals with mental health conditions in their communities are often looked down upon. And there's an additional cultural belief that if we can just wait and see if we can outwill this problem, that perhaps will improve without interventions. What I think is unique in this graph is that we can see the introduction of spiritual and ideological perceptions and the differences between the Black and white community. While the Black and white communities both see major depressive disorder as a problem, the ways in which they rate it as a serious problem are different. There's also an increased introduction to spiritual components that perhaps skew someone's interest or willingness to take these issues to a professional. It is not uncommon for the Black community to experience some physical symptoms related to their depression, and oftentimes wonder if this is in correlation to their physical health instead of their emotional health. It's really critical for clinicians to ask some questions about the manifestation of symptoms and to rule out whether or not these are results of someone's medical condition or a result of some changes in social factors. It's also important to consider the implicit and explicit biases we bring along to a patient's experience. Research has shown that providers may often believe that patients within the Black community have resilience and a willingness to manage their depressive symptoms independently without interventions. There's also been studies that show that chronic medical conditions can sometimes impact the provider's ability to assess whether or not symptoms like fatigue or insomnia are a result of someone's emotional health or physical health. Interestingly, women in the Black community, especially compared to people in their community who are not experiencing depression, report higher instances of fatigue, insomnia, self-hate, and self-blame. Disparities related to healthcare access also impact a person's ability to be diagnosed. We can assume that there are still significant institutional and structural implications that contribute to oppression and lack of healthcare access, particularly in the Black and Brown community. In Black communities where there were less than 8 healthcare providers per 10,000 people, the prevalence of diagnosed depression was 5.7%, compared to 6.6 in Black communities with greater than 8 behavioral health providers per 10,000 people. Representation also matters to the Black and Brown community. This graph shows that people who identify as Black or Hispanic have a higher preference to be able to see providers who have either had similar life experiences and or look like them. There is certainly some historical context about why fear and mistrust happens within the healthcare settings, particularly for the Black and Brown community. In particular, respondents mentioned that they're much less likely to go seek help from a professional that does not look like them. There is additional fear of treatment within the Black community that places individuals at a higher risk of not seeking psychiatric treatment. These images show that the Black and Brown communities are very likely to seek out mutual support from friends, family, spiritual places, and much less likely to seek out influence and support from the professional healthcare providers. So what I think that we can celebrate is that they are talking about issues with people that they love and trust. And our opportunity missed is how can we start to engage Black and Brown communities in a trusting relationship with their healthcare providers. There's also a discrepancy in the philosophy of healthcare in certain highly populated areas. what we find is that highly populated white communities will often receive more pharmaceutical-based treatments for their major depressive disorder. And so this can significantly impact the Black and Brown community's ability to access medications for their depressive disorder if they have a higher population of Blacks and Hispanics. The claims data also reinforces this narrative, showing that white beneficiaries are more likely to receive any type of treatment for depression. There's also a pretty significant discrepancy on whether or not the Black and Brown communities are receiving access to medications, referrals for outpatient talk therapy, or a correlation of both. Another important discrepancy to note is that if and when people are enrolled in mental health treatment for their depressive symptoms, their trajectory for treatment seems to last longer. This inequity is pretty important because we need to consider the costs associated with a patient's experience in treatment. If they do have health insurance, wonderful. But they are still going to be incurring cost in terms of time spent in treatment and on their medications and treatment methodologies that are significantly higher than those in the white community. So what do we do? There are a couple of ways that we can significantly influence this very rapidly and require just a level of insight that maybe we don't have today. The first thing I think that's important to note is that cultural competency can go a long way in the patient's experience. What we're asking in this scenario is that you have an understanding of cultural backgrounds, that you have an acceptance and awareness that people bring different life experiences that are related to their social identities and social groups, even in the medical field. We ask that you have some awareness of your personal experience in relation to your racial groups and your ethnicity, and have an understanding that there are some facts that are important to consider in your treatment planning process. The other side of this that's important to remember is cultural humility. So while we do have competence in knowing that there are differences, we have a radical acceptance that there is no true shoe that fits all people. So I ask that you just take some time during your regular practice to critically reflect on yourself. How am I experiencing this? Am I present with the patient? Am I listening to their experience? And am I not making assumptions based on what I think I know to be true? This level of vulnerability that you're going to bring to the patient's care experience is really going to impact their ability to establish trust and a willingness to have conversations about their emotional distress. This also really helps to tear down some of the walls that we've historically built in terms of people being able to access readily and availably the healthcare industry's very complicated and segmented treatment pathways for depression. So if someone is coming to you to talk about medications, it's a beautiful opportunity to explore their reluctance towards other treatment methodologies, or vice versa. If they're coming to you to talk with you about getting into therapy, you can start to uncover reasons why they might be mistrusting of medical interventions. And I will transition to Caroline, who's going to talk about different treatment options.
As Kayla mentioned, there's significant barriers to Black and Brown community members to be screened for depression and to be treated for depression. And even when they're in face-to-face with a provider, oftentimes their depression is undiagnosed. So we're going to shift here and talk a little bit about the treatments for major depressive disorder and how oftentimes, even if patients begin to receive treatment, the treatment isn't adequate to bring them into remission. So sometimes treatment is initiated and then the failure to augment or the failure to increase dosages leave patients in substandard care. So when we look at what the recommendation is that patients who are being treated for major depressive disorder should really by month 3 be into remission. So their symptoms are decreasing and they're feeling better. Oftentimes that's not the case. Actually, 2 out of 3 patients receiving a first-line treatment do not receive remission, and there's some cost to that. So patients have been willing to engage in treatment, take medication. They're not feeling better. They're often dealing with side effects. Their treatment hasn't been advanced. And this can also contribute to why they discontinue taking medication. And this is also identified in patients who are diagnosed with treatment-resistant depression. So there is some subclass of patients, possibly up to 30%, that actually have treatment-resistant depression. While there's no standardized definition, typically in the literature we look at 2 adequate trials that the patients have not received some remission. Oftentimes the patients may not have had an adequate duration of the medication trial, so that's a contributing factor. So sometimes we talk about whether or not it's treatment-resistant depression or pseudo-treatment-resistant depression. So if the patient really hasn't had 2 adequate trials in terms of the amount of time, the duration of taking the medication, or if the patients decide to discontinue the medication before the adequate trial, that may actually be pseudo-treatment-resistant depression. When we're looking at whether or not it's treatment-resistant depression or pseudo-resistance, there was a study that looked at close to 4,000 Medicaid claims of people on a second-line agent. There are a lot of factors that impact treatment-resistant depression and sometimes pseudo-resistance, and that includes patients' non-adherence to the care plan, failing to have the adequate duration of time for the care plan, and or advancing to a second-line agent prior to 2 adequate regimens. And the consequences to the patients of non-remission in major depressive disorder are significant. So oftentimes patients have continued symptoms. They'll also have recurrent, more severe depressive episodes and a shorter time in which their symptoms relapse. And there's great consequences to this. We know that patients that are suffering from depressive disorders certainly have a greater suicide risk. They're also impacted by their capacity to do things they enjoy, ability to work, and engage in family activities and in their communities. So we really want to do a better job, especially with Black and Brown communities in terms of screening and identifying depressive disorders, but also assuring that we're providing the best possible treatment as well as advancing the care plan to help people reach remission. Adherence is certainly an important thing to consider when treating major depressive disorder. So often think like patients who have MDD, one of the symptoms is that they may not adhere to the medication, and in part because of the symptoms of their disease. And it's very important for clinicians when they're talking to patients about the recommended course of treatment that they go over the adverse symptoms that patients might engage in, because this will help them in terms of their ability to stay on the therapies. And that duration in which they're staying on the therapies will certainly help them get into remission. So as Kayla discussed, there's certain cultural things that we have to consider when we're treating Black patients who have major depressive disorder. And the research has suggested that oftentimes Black patients with depression do have lower adherence to the therapies compared to their white counterparts. And this certainly can have to do with both access to care as well as lack of trust in the healthcare delivery system. Oftentimes in these focus groups with Black women, they disclosed a disappointment in their previous mental health engagement in care. And this leads to increased reluctance to trust new care providers or to engage with the mental health system at all. And some of the participants who had never received treatment reported that they were reluctant to initiate therapy because of concerns that the therapist simply wouldn't understand or know how to help them. And this sort of talks about the disparity in healthcare providers too. When we look at the distribution of mental health therapy providers, oftentimes Black and brown people are reliant upon white providers just because of the distribution of care providers in the mental health community, treatment community. Certainly one big factor in terms of the treatment of depressive disorder is that many of the psychopharmacology agents do result in weight gain and metabolic risk to our patients. And when you have a certain level of mistrust, then you start these medications and then you experience weight gain. This oftentimes leads people to be non-adherent with care. And when we look at certain populations where there's a greater prevalence of obesity and metabolic risk factors, especially in Black individuals, oftentimes with comorbid diabetes, clinicians definitely need to be aware of the risk of weight gain associated with utilization of these medications, to discuss the possibility of weight gain with the patients and also to mitigate that in order to increase adherence. Diabetes is definitely another chronic medical condition that burdens the Black and brown community even more so than the white communities. So I always say depression and diabetes are sort of hand in hand. There's a greater incidence of diabetes in folks that are depressed, and there's a greater incidence of depression in folks that have diabetes. And that bidirectional relationship has some shared conditions around genetics, lifestyle, and psychosocial risk factors. So when treating depression, it's most important to be cognizant of the diabetes risk, as well as when treating diabetes. It's often very important to address depression, and sometimes those things can get overlooked rather than seen through the same lens. And this certainly is more prevalent in the Black community, so we do need to pay attention to having a comorbid treatment plan for diabetes and depression when we're treating our patients. Non-adherence or early discontinuation is often what impacts whether or not a patient will stay on a care plan and whether or not they'll achieve remission. What has been found is that oftentimes, if a clinician does a very good job of explaining to the patient what the adverse events they may encounter when taking the medication, and that those psychoeducational conversations are part of treatment discussions, then those patients are much more likely to stay on and adhere to the treatment plan. Early discontinuation often happens when the patient has a lack of knowledge as to what the adverse events are that they may experience, especially in the first couple weeks of treatment. And many patients stop taking antidepressants because of weight gain, fatigue, and sexual dysfunction. So it's really important to have those clinical conversations at the time in which the medications are selected and being prescribed to the patient. So there are strategies that clinicians can successfully engage in to make sure that their patients are getting the best quality care, as well as the patients have the most likelihood to adhere to the treatment plan and start feeling better and have some remission from their depressive symptoms. And as I mentioned, patient education can't be underestimated here. The patients need to know what the medication is, what the side effects are, what the duration of treatment is, and what they will be expected as a patient to experience, and when to contact their provider with their side effects to have a conversation rather than discontinuing the medication. For patients with major depressive disorder who are not responding to the initial treatment plan with an optimally dosed antidepressants, clinicians can either switch treatment or augment treatment. And a lot of research has been done looking at whether it's better to switch treatment agents or whether it's best to augment. Switching from one antidepressant to another minimizes the likelihood of side effects, but results in results in the loss of any partial response that the patient may have been experiencing from the previous therapy, whereas in contrast, augmentation builds upon the previous response and at the risk of elevating the likelihood of treatment-related adverse symptoms. So this chart just looks at augmentation versus switching, and which agents have been used in those research studies. So with augmentation, you get a 27 to 30% remission, and with switching, 19 to 32%. There was a systematic review of monotherapy studies in patients with MDD with inadequate responses to first-line SSRIs or SNRIs. Patients that were on the vortioxetine were less likely to withdraw because of side effects, which meant that they were more likely to stay on the regimen, and then they were more likely to have higher remission rates. In the well-known STAR*D augmentation trial, which is probably the most widely known trial, adults with major depressive disorder without remission, despite a mean of close to 12 weeks of citalopram treatment, were randomized to receive either bupropion or buspirone as augmentation. They had similar rates of remission with the use of the Hamilton scale, and a little bit greater reduction using the QIDS SR score, and they had a lower dropout rate due to intolerance, 12.5 versus 20.6. So that was statistically significant. What we also learned in the STAR*D about switching was that there were patients without remission of symptoms, some of whom were intolerant of the SSRI. They were randomized to 3 other agents, other SSRIs and SNRIs. The treatments did not differ significantly with respect to the outcomes, tolerability, or adverse events. Overall, 21% achieved remission, 9% responded without remission, and 58% had no meaningful effect. These are kind of concerning. People are engaging in treatment plans, and only half of the respondents and 2/3 of the remissions occurred after 6 weeks of treatment. The VAST-D study looked at switch versus augmentation. Patients were randomized to switch to bupropion, augment with bupropion, or augment with aripiprazole. Remission rates at 12 weeks were 22.3% for the switch group, 26.9% for the augment bup group, and 28.9% for the augment aripiprazole group. The augmented aripiprazole exceeded the switch in remission, and the other remission comparisons were not of statistical significance. So essentially, the response was greater for the augmented aripiprazole, 74.3%, than for the switch, 62.4%, or augment, 65.6%. And in the same VAST-D study, when we're looking at switching versus augmentation, there really was no significant differences observed for relapse. Some patients did have more anxiety in the bupropion groups in both the switch and augmentation. And the adverse events were more frequent in the aripiprazole, which included somnolence, akathisia, and weight gain. In the Optimum study that looked at adults greater than age 60 with treatment-resistant depression, there were 2 steps, 10 weeks each. In step 1, they were randomized to be augmentation of an existing med with aripiprazole, augmentation with extended-release bupropion, or a taper of the current antidepressant and switch to an extended release. And then in step 2, the participants who did not benefit randomized to augmentation with lithium or a switch to nortriptyline. The results of the Optimum study yielded that there were pretty much basically the same results for all groups. There was less fall risk for the patients in the aripiprazole augmentation group. Now we'll look at the psychopharmacology agents in the treatment of major depressive disorder. This slide lists all the different agents in the different categories. So typically first-line agents are SSRIs, oftentimes augmented with atypical agents or switched to SNRIs. There's certainly use of serotonin modulators, tricyclics, teracyclics, and MAOIs. We wanted to talk a little bit today about vortioxetine. This was approved in 2013 for the treatment of major depressive disorder. There's been a systematic review of 15 randomized control studies looking at how it outperformed placebo in terms of response, remission, and depressive symptoms, and it performed very similarly to SNRIs. One thing is that patients reported fewer adverse events when taking vortioxetine compared to other SNRIs. So this may help with patients tolerating treatment plans and staying on their treatment. Of great significance is that it's not associated with significant weight gain, which is often an important issue for patients in clinical trials. When looking at vortioxetine compared with another SNRI, one thing of significance is that at week 8, patients were achieving symptomatic and functional remission, and on 2 interesting scales, one, the functioning assessment short test, as well as the quality of life enjoyment and satisfaction questionnaire, they showed significant improvements. So this is indicating that they're not only getting symptom relief, but they're also able to participate more fully in their daily lives. Another agent is dextromorphan bupropion. This was included in the Gemini study, which randomized patients with major depressive disorder to a study group, and then another group received a placebo over a 6-week period of time. There was a greater change from the baseline in the MADRS score for those patients, achieving remission by week 6. And this was very statistically significant, 39.5% versus 17.3%. There were some adverse events, including dizziness, dry mouth, headache, nausea, and somnolence, but treatment was not associated with the other effects, which often lead to patients not staying on treatment, specifically weight gain and increased sexual dysfunction. Another treatment is esketamine. It was approved in 2019 for the treatment of treatment-resistant depression and major depressive disorder with acute suicidal ideation as an adjunctive therapy, and in 2025 was approved as a monotherapy. As a monotherapy, participants who received esketamine had significantly greater improvement in their MADRS total score compared with the placebo by day 28. Common adverse events for esketamine include dizziness, dissociation, headache, nausea, and somnolence, but these treatment side effects typically do not interfere with the patient staying on treatment. The rapid onset of effect with esketamine makes it particularly well suited for treating patients with suicidality. Another agent that can be used are atypical antipsychotics, all approved for adjunctive therapy for the treatment of patients with MDD. And when added to antidepressants associated with a greater change from the baseline in the MADRS score compared to placebos. With these atypical antipsychotics include fatigue, increased weight gain, headache, somnolence, and nausea. Lumateperone is an additional atypical antipsychotic that is currently under review. It was approved for the treatment of schizophrenia and bipolar depression as a monotherapy or as an adjunctive therapy with lithium or valproate episodes. It's currently under review as an adjunctive treatment for major depressive disorder. It may normalize dopamine transmission and reduce risks of adverse events associated with dopamine blockade with little to no EPS. Lumateperone is currently in phase 3 trials and includes patients with major depressive disorder with inadequate response to monotherapy. Somnolence, dizziness, and nausea, most frequently reported AEs. Metabolic and weight changes were similar for lumateperone and the placebo. In the schizophrenia trials, lumateperone had favorable metabolic effects, including a decrease of total cholesterol and LDL, and a shift from overweight to normal weight and from obesity to overweight. So wrapping up, I'd just like to go over some key takeaways from this activity. Initially, we talked about and learned that Black individuals are much more likely to not have access to care. They're less likely to be screened for depression. They're less likely to get either pharmacological or mental health therapy. And if they do get therapy, there's oftentimes a long delay before the pharmacological therapy is introduced. 2/3 of patients receiving standard first step treatment with an SSRI do not achieve remission and are at risk of relapse. There's lots of reasons that patients may not adhere to their treatment plan. Oftentimes it's related to adverse events and side effects, and this can be mitigated by good patient education and psychoeducation on the front end. And strategies to improve response include augmenting with another medication or switching to another antidepressant to assure that patients are treated for major depressive disorder and are able to get into remission. And now I'll turn it over to you, Tabitha.
And now let's revisit those questions you saw at the beginning of our program. As before, the questions will pop up on your screen. Please take the time to provide your answer. Question 1. Which of the following is true about the treatment of major depressive disorder among Black individuals when compared with white individuals? Black individuals are more likely to provide your answer, please. This is how you responded previously, and this is how you responded now. Kayla, what is the correct answer?
The correct answer is experience delays in receiving medical treatment. Studies have been showing that Black individuals are less likely to receive medication in primary care, be referred to psychotherapy, or a combination of the two, medication and psychotherapy. They're also more likely to experience delays in receiving any type of medical treatment.
Question 2. A 45-year-old Black woman with newly diagnosed MDD was started on an SSRI 6 weeks ago. At today's visit, she reports she stopped taking the SSRI 2 weeks ago because of fatigue and weight gain. What is the most appropriate next step to improve treatment adherence and response? Please answer now. This is how you responded previously. And these are your responses now. Kayla, what is the correct answer?
The correct answer for question 2 is B, educate about expected side effects and strategies to mitigate them. Clinicians should really prioritize this patient education, particularly about side effects that they should expect when trialing medications. It's the best opportunity to mitigate any type of reluctance or quick stops to their medication regimen. It also helps to mitigate the risk of patients essentially altering their medications on their own. Clinicians should also be mindful about assessing the symptoms during treatment and distinguishing if there's a medication side effect or any types of worsening symptoms related to their depression.
Question 3. Which of the following has demonstrated increased rates of remission of depression as a switch agent after inadequate response to first-line antidepressant? You can provide your answer now. And this is how you responded at the beginning of our program. And these are your responses now. Kayla, what is the correct answer to question 3?
The correct answer to question 3 is vortioxetine. Vortioxetine is an antidepressant that may be used in monotherapy. And while other agents are useful in adjunctive treatment, this is the answer we're looking for.
Thank you, Kayla, for your responses. As I mentioned at the beginning of our program, we're partnering with Lancaster and Philadelphia area barbers for our Fade Out Depression program. Our team will be educating barbers on how they can start conversations with their clients around major depressive disorder. Our barbers will be provided with a list of clinicians that have completed the education so that they can refer clients for depression screenings. We will also be hosting an MDD screening day at a Lancaster area barbershop where our faculty will be present to assist with screenings. If you are interested in being part of our clinician referral network, please email us at twashington@dkbmed.com. I want to thank our faculty for a wonderful education session today.
I appreciate the opportunity to partner and fade out depression and increase awareness and knowledge about the treatment of major depressive disorder and identifying its incidence in the Black and Brown communities.
Thanks for having us. We're really looking forward to this next step of the project and getting out into our community.
And I also want to thank you, the learner, for joining us. Please remember to complete the evaluation shown on the console to claim your education credit. For more information, contact us at info@dkbmed.com. Thank you, and we look forward to seeing you again.